Hi everyone, this is Nafis, and welcome to another episode of Medical Mayhem. This episode is called The Lactating Schizophrenic Patient. So, let's get right into it. A 31-year-old woman with recently diagnosed schizophrenia complains of an ants-in-the-pants feeling. She can't sit for more than 5 minutes without feeling the need to get up and move around. She has no history of ADHD. She also endorses a resting tremor. You notice the shuffling gait as she was walking into your office. She also complains of bilateral breast discharge. Her schizophrenia was diagnosed 2 months ago, and you prescribed her haloperidol at that time. So what's going on here? Well, to answer that question, we should bring our attention to what that brain of hers is doing. We want to look at the pathways in the brain that involve dopamine. So let's zero in on this pathway right here called the mesolimbic pathway, which connects the ventral tegmental area of the midbrain to the nucleus accumbens. This is actually the reward pathway that people commonly think of with dopamine as the so-called pleasure chemical. Eating chocolate, winning the slot machines at the casino, kissing your girlfriend. All of these things ramp up the activity of this pathway, bathing your brain in that juicy dopamine, making you feel really good. When this pathway gets out of control and starts pumping out dopamine on its own, whether something pleasurable happens or not, that's what triggers what's called the positive symptoms of schizophrenia. When this part of your brain is soaked in dopamine, you start getting hallucinations, seeing and hearing things that aren't there, like voices telling you that your videos suck. Hopefully that just stays in the comments section. Another positive symptom of schizophrenia are delusions, which are fixed false beliefs, like thinking that the government is tracking your every move with a chip in your brain, or that you would actually hit the subscribe button under this video. Well, hopefully the last one isn't a delusion. So if these delusions and hallucinations are caused by too much dopamine binding to receptors in the mesolimbic pathway, the solution is pretty obvious, right? Just get rid of some of the dopamine so we can turn the mesolimbic pathway down a notch. And that's exactly how first-generation antipsychotics like haloperidol work. They're dopamine antagonists that hog the dopamine receptors so that dopamine can't bind, which shuts down the mesolimbic pathway. And that decreases the positive symptoms of schizophrenia. Amazing, right? Problem solved? If only anything was ever that easy. You see, the problem is that there are other pathways that use dopamine as well, that we might not want to shut off. The two main ones that I'm going to highlight are these two, the nigrostriatal pathway and the tuberoinfundibular pathway. The nigrostriatal pathway is what goes from the substantia nigra to the striatum. It's the part of the brain involved in motor function. This stuff can get pretty complex, and I'm going to try to stay away from the nitty-gritty details, but what you should know is that the substantia nigra contains a ton of neurons that churn out dopamine to initiate movements and coordinate fine motor control. These dopamine-producing neurons actually die off in Parkinson's disease. So this whole pathway that normally triggers and regulates the motor movements gets screwed up. And you get all these classic things you think of with Parkinson's, like tremors, bradykinesia, which is slowness in starting movements, and shuffling gait. As you might expect, when drugs like haloperidol tell dopamine to knock it off, this pathway gets screwed up and causes a state similar to Parkinson's disease. This is actually called Parkinsonism, and it's a well-known side effect of first-generation antipsychotics. It's not just Parkinsonism, though. All kinds of motor symptoms indicating a lack of control can happen when you lose the motor regulation from the nigrostriatal pathway. Akathisia, which is the jittery feeling with the urge to constantly move around, and lip smacking, known as tardive dyskinesia, are two more. This cluster of motor symptoms is called extrapyramidal symptoms, or EPS. The other pathway that I want to draw your attention to is the tuberoinfundibular pathway, which connects the hypothalamus to the pituitary gland. Basically, one of the many hormones the pituitary gland secretes is prolactin, which, as the name implies, triggers lactation. When the hypothalamus decides we don't need any breast milk, it talks to the pituitary gland with dopamine. When the pituitary is producing too much prolactin, the hypothalamus hits it with dopamine, telling it to knock it off. This is how it keeps the prolactin levels in check, so there isn't milk constantly oozing from the nipples. When you block the dopamine with antipsychotics, you lift the brakes on prolactin release. The pituitary starts secreting prolactin out of control, and prolactin levels in the blood surge, which is called hyperprolactinemia. Women experience bilateral breast discharge due to excessive lactation, or galactorrhea as a result. The hypothalamus normally releases gonadotropin-releasing hormone, or GnRH, which stimulates the pituitary to release gonadotropins like FSH and LH, which increases sex hormones estrogen and progesterone, which allows for normal ovulation and menstruation. When there's too much prolactin in the blood, the prolactin inhibits the release of GnRH from the hypothalamus, suppressing these sex hormones. So in women, hyperprolactinemia also causes amenorrhea. So let's recap. Using this dopamine blocker haloperidol might reduce the delusions and hallucinations in schizophrenia by blunting the mesolimbic pathway, but blocking dopamine can shut off other important pathways that use dopamine as its currency, which are the nigrostriatal and tuberoinfundibular pathways. This causes the extrapyramidal symptoms and hyperprolactinemia that we worry about. So if we go back to our case, it's pretty clear what's going on here. She started taking haloperidol, and it's obvious that she's having extrapyramidal symptoms. The ants in the pants feeling, any idea which extrapyramidal symptom that is? If you said akathisia, you'd be right. The tremors and shuffling gait? That's Parkinsonism. Both are extrapyramidal symptoms. And the bilateral breast discharge? Hyperprolactinemia causing galactorrhea. Because which pathway is blocked? The tuberoinfundibular pathway. So you decide that the haloperidol is causing trouble. So you switch her over to a second-generation antipsychotic or atypical antipsychotic. These are different because they are more targeted in their dopamine blockade to the mesolimbic pathway. The other pathways don't actually suffer as much. You get less EPS and less hyperprolactinemia. Amazing. Treating the schizophrenia without the nasty side effects? Problem solved, right? Well, not quite. The downside of atypical antipsychotics is that while the unintended effects of dopamine blockade are not as severe, they tend to increase the risk of metabolic syndrome. Metabolic syndrome basically consists of all the things that come to mind when you think of someone that's unhealthy. Obesity, hypertension, hyperlipidemia, diabetes, the whole 9 yards. And atypical antipsychotics are associated with this. So with this in mind, let's pick an atypical antipsychotic for our patient. Let's go with paliperidone. She comes back in 2 weeks and says she's still having the same symptoms, but they're not as severe. Why is that? Remember that these drugs don't eliminate EPS. There's still some dopamine blocking going on in the nigrostriatal pathway. So we can give her a drug called benztropine, which reduces EPS. She comes back in 2 weeks, and her motor symptoms are pretty much gone. She still has the breast discharge, but she says that she'll deal with it. Now it's a happy ending, right? Schizophrenia is under control, EPS is gone, her breast discharge isn't really a big deal. Well, she comes back 2 years later and complains of headaches and vision changes that she's had for about 18 months. She's almost gotten into several traffic accidents because she couldn't see cars coming from either side. She complains that she's had irregular periods for a while, most recently missing 10 cycles in a row. When she does get menses, it's very heavy, going through about 20 pads a day. She's also gained a significant amount of weight and is now at a BMI of 36. These days, she's noticed that she's been more thirsty and urinating much more frequently. Visual field examination reveals a loss of vision in the peripheries. You decide to get some blood work. Here's a summary of the exam and investigations. Just take a look at some of the data I've highlighted. Hypertensive, high lipids, obesity, and increased glucose. Sounds a lot like metabolic syndrome. This is exactly what we were worried about when starting her on an atypical antipsychotic. And the headaches with decreased peripheral vision? It's a pituitary tumor. The loss in vision in the peripheries is because the tumor presses up against the optic chiasm, which is right over the pituitary gland. The chiasm carries nerve fibers from the temporal sides of our visual fields. So a tumor compressing this causes the loss of vision specifically in the temporal sides. This is called bitemporal hemianopsia. Here's the patient's MRI showing optic nerve compression. Any guess on what kind of pituitary tumor this is? It's a prolactinoma, a pituitary tumor that secretes prolactin. That explains the persistent galactorrhea that we thought was a residual side effect. But nope. We assumed she had the galactorrhea because of her meds, but actually she's been having it since her late 20s, before the schizophrenia even started. It also explains the amenorrhea. Remember, prolactin can shut down the release of GnRH from the hypothalamus, which is needed for ovulation and menstruation. So what do we do about this mess on our hands? Let's think. Going back to what we know about the tuberoinfundibular pathway, dopamine is how you shut off the prolactin release. So we use a dopamine agonist like bromocriptine to tell the pituitary to cut it out. When we do this, the prolactinoma tends to shrink without the need for surgery. But we have another problem down below. She's had all of those anovulatory cycles and heavy bleeding. That rings the alarm bells for endometrial cancer. Let's quickly review normal menses. What normally happens in menses is the pituitary gland releases LH and FSH that increases estrogen and progesterone. The estrogen is what builds up the endometrium, and then progesterone comes in and causes it to shed, and then you get menses. In the case of hyperprolactinemia, Prolactin inhibits gonadotropin release by the pituitary. So what happens is you get anovulatory cycles, which results in endometrial buildup without shedding from progesterone. The fact is, she's had endometrium that's gone months without being shed off. And when she does bleed, it's 20 pads. That shows that things are really getting thick over there. It's building up and building up without the gonadotropin, specifically LH, to increase progesterone to keep it under control. So when it does shed, it's a lot. But how is it building up if prolactin suppresses the other gonadotropin, FSH, that promotes endometrial thickening by increasing estrogen? Good question. By switching her over to an atypical antipsychotic, we gave her metabolic syndrome. There's a ton of adipose tissue sitting around, which has an enzyme called aromatase. This converts androgens to a form of estrogen called estrone. And estrogen, as you know, is what promotes endometrial bulking. So even if you don't have much FSH, which normally increases estradiol to build up the endometrium, you have a huge supply of estrone that takes its place. And this is why obesity is one of the biggest risk factors for endometrial cancer. In this poor lady's case, anovulatory cycles and a tidal wave of estrone equals cancer. Let's get a pelvic ultrasound to confirm our worst fears. The endometrial stripe thickness is 14 millimeters. That's thick. We start worrying about endometrial cancer at a thickness of 4. The endometrial biopsy on the right again confirms the presence of cancer. To recap what happened, we gave a schizophrenic woman antipsychotics, which we thought was the reason she was having breast discharge, but it turned out a prolactinoma was the real culprit all along. The chronic amenorrhea she was having from the hyperprolactinemia, and the fact that she became obese due to the metabolic effects of atypical antipsychotics resulted in prolonged endometrial proliferation without menses, progressing to cancer. Thanks for tuning into this episode of Medical Mayhem. If you enjoyed it, please like the video, share it with your friends, and subscribe to the channel. Until next time, this is Medical Mayhem.